2017, Natalie was awarded Health Foundation Improvement Science Fellowship, which is using kind of social science theory to look at the topic of overdiagnosis and overtreatment within the UK healthcare system, and how this can be balanced with efforts to prevent undertreatment. And I think it's some of the ideas emerging from that work that Natalie's going to talk to us about today. But Natalie is a real proponent of working in an applied healthcare research setting to do research that's going to be useful and usable by healthcare staff, policymakers and others. And that's why I think it's absolutely fantastic to have Natalie here today, because she really does have the same kind of set of underlying values that we do as a group. So Natalie, thank you for joining us, and I'm going to hand over to you. And if there's anything else you want to say by way of introduction, please do.
Okay, thank you ever so much, Rebecca, and thank you for the really kind invitation to talk to you today. I wish I could be with you in person, but instead I come to you from my spare bedroom at home, where it feels like I've been for virtually forever. So I'm just going to share my slides with you, and we did practice this before, so I'm hoping it's going to work okay. Can people see those?
Yes, we can.
Right, good. Okay. So, as Rebecca said, the main thing that I'm going to talk to you today about is work, thinking and writing that I've been doing over the last 3 years or so, while I've been funded, very fortunately, by the Health Foundation through one of their Improvement Science Fellowships. And the work that I was doing through that fellowship was thinking about doing less in healthcare, tackling issues of overtreatment, overdiagnosis, overuse, and I'll say a little bit more about terminology as we go through, but also thinking about how, there are lots of quality improvement interventions which are about making sure that things are happening rather than trying to stop things happening. So one of the things I'm interested in thinking about is the kind of balance between potential over and underuse, and how within healthcare systems we can think about what an appropriate balance is and how we can try and ensure that. So this is what I'm going to focus on talking about today. So I've just put my contact details, my email address on that slide. If you want to contact me, you're very welcome to, and that's my Twitter handle as well. So the idea that we could have too much medicine is not necessarily a particularly new idea, but it's an idea that's been gaining traction, I would argue, over the last few years. And there are lots of policy documents and statements and activities that can evidence this, and you might be familiar with some of these. So just as some examples, this is a report by the OECD from a year or two ago, which was essentially making the argument that a considerable part of health expenditure actually makes little or no contribution to improving people's health. And in some cases, it can actually make health outcomes worse. So the suggestion is that countries could actually spend less on healthcare with no very significant impact on health system performance or on health outcomes. This is an example from the BMJ. You might be aware of their Too Much Medicine initiative, which, as it says here, sort of highlights the threats and possible harms of too much medicine. And they focus particularly here on overdiagnosis and waste of resources on unnecessary care. And they have quite an active set of papers, both research papers and more analysis viewpoint pieces that appear quite regularly within the BMJ. And also we have campaigns, movements, advocacy initiatives, and this is one example. So this is Choosing Wisely, which is an international organisation, campaigning organisation, which has some kind of core underpinning concerns around choosing wisely about the kinds of things that we do within healthcare, and has national versions in a number of countries around the world. And I'll say a little bit about the UK version in a minute or two. But one of the things that I think it's important to start with is to acknowledge that definitions can be tricky, and there's various competing or potentially complementary language in this kind of space around overuse. And I've just chosen a couple of examples here which focus particularly on overdiagnosis. But other terms that you often see in the literature or within policy or practice discussions might be around low value care or overuse, as we've got here, overdiagnosis, overtreatment. There's different language that's used, which as a sociologist I find interesting, because one of the things that it makes me think about is what kind of values are being conveyed in this language. Who determines what's overuse or overtreatment? Who determines what's low value care, and using what kind of principles? And what kind of normative judgments might be at play here, either implicitly or explicitly, in talking about care and care interactions and care activities in this kinds of ways? So on the left-hand side, we've got a kind of screenshot of a paper by Stacey Carter and colleagues in the BMJ as part of the Too Much Medicine series, who are have been giving some thought to thinking about how we define something like overdiagnosis. And they argue that we should perhaps use a broad term such as too much medicine for advocacy purposes, to kind of get that general message across. And they advocate for developing more precise case-by-case definitions of overdiagnosis for research and clinical purposes. And I think it's an interesting question as to whether that's actually doable in practice and how you might go about doing that. And then the other example is from a piece by John Broderson and colleagues from BMJ Evidence-Based Medicine. And again, they're focusing on overdiagnosis, and as the title there says, what it is and what it isn't. And they seek to draw distinctions between different forms of overdiagnosis. And these include overdetection, which is essentially finding things that didn't need to be found. And that's a concern that's often raised in relation to population-based screening, for example, the idea that you might find anomalies that actually aren't a problem and aren't going to go on and cause a problem, but that you end up intervening for and treating in some way. And then another example that they talk about is over-definition, and that includes things like the lowering of thresholds for a risk factor for a particular condition, or by expanding disease definitions to include more patients who perhaps are a bit borderline or have only milder symptoms or something like that. But when I'm sort of thinking about overdiagnosis and overtreatment, I sort of tend in my head to sort of work with a definition that's around a diagnosis being correct in terms of current standards, so not kind of misdiagnosis or that sort of thing, but in cases where the diagnosis or the associated treatment that might follow on from it has a low probability of benefiting the patient, and there might be questions about benefit in what terms and who gets to decide that, and may instead be harmful. And that harm might come for an individual patient in terms of side effects of medication or an intervention, or in terms of raised anxiety levels, or it could be in terms of opportunity costs within healthcare systems. If we're spending money on something, then you don't have that same money available to spend on something else. So thinking about how we might go about trying to ensure just enough medicine, as I said at the beginning, I'm interested in this balance, or whether we can strike a good balance between under and overuse and under and over diagnosis and treatment. And I like to use this picture of some porridge, because for me this kind of really conveys or really gets to the issue about what does just enough look like. If you think about Goldilocks and the Three Bears, you know, how do we get the porridge for somebody that's just right, that's not too hot, it's not too cold, it's not too thick, or it's not too lumpy, or it's not too watery. Your porridge might look very different to my porridge. Goldilocks didn't care for Daddy Bear or Mummy Bear's porridge, but Baby Bear's was just perfect for her. So I think they're really interesting questions about how we decide what just enough is, and recognise that that may well look different in different circumstances for different patients. So as a sociologist, one of the first things that I wanted to do in my fellowship was to spend a bit of time thinking about what medical sociology might have to say around these issues of predominantly overdiagnosis and overtreatment. And I spent some time thinking about medicalisation, which, if I know we have some sociologists in the meeting, is obviously, you know, a very well established concept. And so I wanted to spend a little bit of time thinking about that. And I think overdiagnosis and overtreatment sort of explicitly are yet to receive, I think, any very significant sociological attention over and above that, which is arguably transferable from the medicalisation literature. Interestingly, though, the issues did feature in an exchange on the continued relevance of medicalisation in the pages of the journal Sociology of Health and Illness. And I've just put screenshots of 3 papers that formed that exchange. So Joan Busfield, who's a very well-known sociologist, was seeking to assess the concept of medicalisation and consider whether it still had value in exploring significant aspects of medicine's role. If you haven't read the paper, there's a spoiler, she thinks it does. But what was interesting to me is that Simon Williams and colleagues responded to this essay that Joan had written. They raised a number of issues with it, actually, but one of them was what they saw as her lack of attention to issues at least aligned with, if not the same as, concerns around overdiagnosis and overtreatment. And one of the interesting concepts they highlighted here was between medicalisation, which in some incarnations at least is a sort of descriptive value neutral term, and the focus increasingly recently on overdiagnosis and overtreatment as having a very clear status as a value-laden concept, to be very clearly labelling these things as problematic. And Busfield's response was that while it had some interest, she didn't think overdiagnosis and overtreatment had significant analytical value for sociologists, which I think is possibly a fair point in terms of its use as an analytical concept, but I don't think that means we shouldn't think about it sociologically, and that there might not be benefit in doing so, and I'll come back to that a little bit later on. So one of the things that I always struggled with a little bit back in the days when we could go to conferences, I used to go to this annual conference called Preventing Overdiagnosis, which some of you might have heard of. And I used to sit through lots of talks and look at lots of poster presentations at these conferences and see such a really strong focus on shared decision making and decision aids as, you know, the way through which these issues would be tackled. And I was increasingly uncomfortable with this. And I think that within that kind of movement, these issues are often construed as best addressed by educating patients and clinicians and encouraging good relationships between them so that they can have an open discussion about possible harms, possible benefits, and come to some shared decision. And the emergence of tools and movements seeking to support decision making and to facilitate patients asking questions about whether tests and interventions are really necessary kind of certainly supports this conceptualization. When you could go to these kind of conferences and you could learn about nothing but new decision aids, you know, there are decision aids everywhere that people have been developing and piloting and testing. But the thing that sort of troubled me was that this conceptual focus on kind of diagnostic, prescribing and treatment behaviours at the individual level kind of marginalises the wider social and political practice of medicine, because issues of responsibility and agency kind of get focused on in terms of these very individual pathways and decision-making points. And as I say, largely ignore the kind of structural issues that influence how healthcare is organised and delivered and managed, which I obviously think are important. And I think this has the potential risk that it generates kind of simplistic, quick fix solutions that don't appreciate that wider context. And importantly, also fail to kind of critically interrogate this ideal of the right amount of medicine and lack a framework within which we can construct or interpret or articulate understandings of rightness and what that actually might mean. So this is going back to Choosing Wisely. So as I said earlier, Choosing Wisely as a kind of international initiative was created, as it says here, in part to challenge the idea that more is better, or in the case of medical intervention, that just because we can doesn't always mean that we should. And this is from the UK Choosing Wisely iteration. So Choosing Wisely in the UK is hosted by the Academy of Medical Royal Colleges. And they have largely 3 broad sort of streams of activity. So firstly is sets of recommendations for clinicians of things that they shouldn't be doing, and they're drawn up by individual Royal Colleges. The second is producing information and some training on shared decision making for clinicians. But the third is on articulating sets of questions for patients to ask of their clinicians. So you can see in the blue box, I think this is the most recent sort of incarnation of these questions using this BRAN acronym. So encouraging people to ask their healthcare professionals, you know, what are the benefits of what you're proposing or suggesting that we could do? What are the risks? What are the alternatives? And what if I do nothing? And it's this idea of nothingness that I'm going to come back to a bit later in the talk. So, as I said, I wonder a lot about the extent to which an exclusive focus, and this might be a bit straw man of me and a bit unkind, but a focus predominantly on shared decision making as the possible means through which to tackle these issues. Because I think that even when professionals and patients might wish to do less rather than more, the system within which care is organised, delivered, received, within which care quality is managed, can make this surprisingly difficult to achieve. So there is starting to be work mapping the kind of wider drivers of overuse and linking them to potential solutions. And this is one example. Again, it's from the BMJ's Too Much Medicine series. It's from some folks in Australia, based largely on literature reviews. And I think this has some value, but I think inevitably can only be a starting point. So this quite busy diagram is taken from this paper. And as you can see, it's got down the left-hand side possible drivers of overdiagnosis, and down the right-hand side some possible solutions. And these are quite wide-ranging, so you can see they're kind of mapped into sort of different elements, ranging from patients and the public in the middle through to kind of culture, whatever that might be, at the outside, but passing through industry and technology and health systems. And you can see that they've sort of chunked the drivers and possible solutions into these broad categories. And I think that while there's obviously lots of relevance here, I think it's interesting to think about, well, actually, how do these drivers or possible solutions work in practice? So if you look at the possible drivers, for example, in terms of professionals, we've got some things that you might not be very surprised about being listed here. So things like fear of litigation, fear of missing a disease because you didn't do absolutely every diagnostic test that you could have done, lack of confidence or knowledge, and over-reliance on tests. And while I wouldn't necessarily dispute those, I think that they might work quite differently in different kinds of contexts, whether that be different clinical contexts, different healthcare contexts, or with different kinds of patients. And if you go across to the linked possible solutions for professionals, you sort of see things listed here like, reform the litigation driver, increase people's comfort with uncertainty, reduce test over-reliance, which is great, but what does that actually mean tangibly in practice, and how might we go about doing any of those things? And I think that one of the things that interests me, as I said, is this tension between choosing not to do something, even though the option is available to you, and making sure that the things that should be happening are happening. And I think this is compounded a little bit by the way in which many attempts to improve care quality can tend to encourage the doing of more rather than less. So if you think, for example, about something like care bundles, the idea that you do all of those things and you can't tick off that you've completed this care bundle until you've done all of those elements. And arguably encouraging also the standardisation of care. We hear a lot about unwarranted variation and wanting to address that. So guidelines intended to reduce variation and improve care have arguably encouraged the neglect of respect for patients' preferences. So I like to think what social theory can offer in terms of enhancing our thinking about how features of healthcare systems can make it challenging for clinicians and patients to do less rather than more, not least because of concerns that doing so might be considered deviant in some way, or is to make you vulnerable or exposed to potential negative consequences or implications. So overuse intersects with evidence-based medicine, which, as I'm sure you know, is proposed as a solution to the problem of practice variation. And the idea underpinning it is that by providing best evidence, we can ensure that clinicians are best placed to deliver optimal care. And indeed, organisations like NICE now sort of spell out, sometimes in quite step-by-step fashion, how to diagnose and treat patients with particular conditions. The issue, of course, though, is effectively managing that potential gulf between the population-based evidence that's available and the individual patient, and also how you translate guidelines which might be quite disease specific into patients who are more complex, have a range of conditions, a range of other things going on. And it's been argued, including in this paper, which you may well be familiar with, that although evidence-based medicine has had many benefits, it's also had some negative unintended consequences. And in this paper, the authors offer a preliminary agenda for what they see as the movement's renaissance, refocusing it as being about providing usable evidence that can be combined with context and professional expertise so that individual patients get optimal treatment for them. And that sounds like it should work really quite nicely, but perhaps it's not that simple. So what I've put up here are just the covers of two books that I like and that I've read quite a lot. So in these cases, thinking about this kind of proposed reinvigoration of evidence-based medicine, in these cases, we might consider clinicians as being able to operate in what Elliot Friedson's characterised as the zone of discretion. So sociological analysis of the professions in general and of the medical profession in particular has long paid attention to the exercise of autonomy or discretion as a key element characterising the work of professionals. And this space for discretion is on the face of it quite promising and appears compatible with this kind of ethos underpinning things like shared decision making, in which preferences are shared and ways forward are mutually agreed. But as I say, things might not be so simple. So the other book cover is a book by Michael Power on the Audit Society. And in this, he's arguing that the growth of the Audit Society is leading or has led to the development of regulatory cultures and new forms of bureaucracy within medicine, which prioritise codified knowledge, such that being a doctor relies more, he argues, on the production and use of encoded and formal knowledge, rather than more tacit knowledge acquired through experience and a feel for the game, which arguably might be some of the most useful knowledge in seeking to mitigate against overuse in particular contexts. And research has shown that doctors are increasingly aware of the potential for complaints, and obviously this was listed as a key driver in the diagram I showed a minute or two ago. And that this means that their practice can become more cautious and more defensive. So in the context of overuse, that might manifest as proceeding to more tests, more treatments, just to be safe, just so you don't miss something. And I think one of the issues that we have is that communicating about overuse or potential overuse depends upon patients being willing and able to mobilise questions and to understand the answers that are provided. And it also assumes that the clinician will be able to pick up on these concerns or these questions, which might be quite tentatively posed, and also has the knowledge and is suitably inclined to engage with and answer them. And this might be particularly challenging in relation to overdiagnosis and overtreatment, because it can be very difficult to know for any individual whether the possible benefits will outweigh any possible harms of any particular intervention or course of action. And the idea that we might be overdiagnosing or overtreating are still, the literature would suggest, still largely quite unfamiliar ideas to some patients, and that they typically expect that healthcare professionals will do something. So communicating about overdiagnosis and possible overtreatment requires acknowledgement and management of uncertainty about possible harms and benefits. And actually the evidence in the area can be quite hotly contested. If you think, for example, about the debates which are ongoing now, but were particularly live a few years ago about the relative merits of breast cancer screening, that's an evidence base which is still quite heavily disputed. Similarly, the use of statins for managing cardiovascular disease risk, again, quite hotly contested evidence base. So this uncertainty about harms and benefits is nested within this kind of wider range of uncertainties and tensions, which include some of the uncertainties about which of many relevant considerations are most important to the patient concerned, and the need to balance responsiveness to patient agendas with other potential considerations. So I like this picture because to me it's just a really nice visual representation of a really complicated system in which you could pull any number of these levers and sort of things would happen, and they might happen in different places, and things might be interconnected or they might not, and it could take an awfully long time for that to become clear. And I think quality measurement that focuses on important processes and outcomes, including things like clinical care and patient experience, is often seen as an essential feature of well-functioning healthcare systems. So I'm interested in thinking about what we might need to do to reorient the system to be better able to support clinicians and patients to do less rather than more. And as we've seen, you know, this fear of possible complaints or possible litigation is argued to be driving defensive practice. So how could we, for example, think differently about how shared decision making could be effectively captured and recorded such that it provided some protection to healthcare professionals? And that might be quite complicated to do because those discussions are likely, I would suggest, to be quite variable and quite personalised to individual patients' contexts. And it's particularly important when shared decision-making discussions result in decisions to do something, perhaps nothing, that can appear on the face of it to run counter to what might be considered good clinical practice and or specific guidelines. And while NICE guidelines are often talked about as being guidelines, not tramlines, many healthcare professionals can feel uncomfortable or can feel nervous about being seen to deviate from those in the care that they're giving. Not least because it can make them appear in some way, arguably perhaps as deviant. So in a paper in BHA Quality and Safety, which is one of the first things that I wrote for my fellowship, I wanted to think about what we can learn from the kind of quality improvement, healthcare improvement research literature in thinking about how we might tackle overdiagnosis and overtreatment and what we can gain by understanding them as a quality problem. And in this, I focused on three key areas. Firstly was the need for clear articulation of the problem and the factors driving it. So as I suggested earlier, moving from that kind of catch-all diagram with, you know, ticks next to things that might be relevant to really think about, okay, how are these drivers, if you like that term, and not everybody does, but how are the drivers working in any particular context? Are they interrelated? How do they actually manifest in practice, and what influences how that happens? And the second was to think about the value of careful theory-informed design of interventions with clearly articulated and credible proposed mechanisms. So again, if you think back to that complex busy diagram and the possible solutions on the right-hand side, how do we select any of those and how do we kind of operationalize them into an intervention that we've got some reasonable assumption might actually work in practice? And then the third was the need for robust evaluation of any efforts to tackle the problem, not just of whether something has worked or not, but sort of whether and how it's worked and for whom and in what situations and what has been required to make that happen. Because I think one of the things that is quite clear is that tackling overuse is often much harder in practice to do than people assume it's going to be, and that the benefits that are there to be had in terms of reducing costs, for example, are often harder to realise than people think they're going to be. So this is just a poster which I presented at HSI UK last year and was supposed to present at the International Forum in Copenhagen this year, but sadly didn't manage to, which essentially summarises a literature review that I did as part of my fellowship. And we were looking at quality improvement interventions, quality improvement projects around reducing overuse. And it was interesting to see the kind of outcomes that were being sought. And there were some of the obvious things that you might expect, like reducing the number of interventions carried out, limiting testing without a clear indication to do a test, minimising prescribing of particular medications. But what was interesting is that characterisation of the problem being tackled was typically fairly weak, with few studies, we thought, demonstrating a kind of clear articulation of the problem and a diagnosis of what was causing it. The interventions that people were using were typically multifaceted and included things that you might expect, like processes of consensus building, developing new guidelines, decision-making algorithms or changes to order sets to sort of actually stop people being able to order tests without a very clear reason for doing so. But few demonstrated that kind of clear theory of change as to how what they were proposing to do was actually going to tackle the problem they were interested in. And although the interventions in most of the studies showed some reduction in the practice of interest, it was interesting that few often fell short on kind of commenting on the appropriateness. So we've reduced activity to some extent, but do we know that it's the right kind of things that we've stopped doing for the right kinds of patients? And relatively few included any kind of balancing measures. So you're stopping activity in one area, but how do you know it's not popping up in slightly different forms somewhere else? So this is a paper that I wrote with Deborah Swinglehurst, which was published in Family Practice, which it largely is just making the same arguments around the need for really understand what this issue is and why it's happening. And this was with the example of polypharmacy, which Deborah works on a lot. And we argued for the use of ethnography as a really good means to really understand why problematic polypharmacy arises, why it persists, and why it can be actually surprisingly tricky to do anything about. This is something else that I did in the course of my fellowship. I didn't plan to do this. This just kind of happened along, and I was delighted to work on it with Nikki McIntosh, who some of you will know is a colleague from the Sapphire Group. And we looked at understanding and managing uncertainty in healthcare for this special issue of Sociology of Health and Illness. And one of the papers in that special issue was this paper by Caroline Cupit and some of us, which was Caroline's PhD work, which was looking at NHS health checks, calculation of cardiovascular risk, and the prescription of statins. And what Caroline's analysis showed really nicely was that often kind of the way in which these checks were being implemented and monitored actually managed out opportunities for real shared decision making, and that patients' concerns or questions about taking statins became framed as barriers that needed to be overcome through further information or further education. So she argued that we sort of showed how this work was institutionally orientated towards performance measures rather than actually meaningfully listening and working with patients to think about what was in their best interests. This is another piece of work that Caroline and I have done quite recently, which was looking at this thing called the Evidence-Based Intervention Programme within the NHS, and looking at how these kinds of things around the role of commissioning organisations, who are ultimately kind of responsible for commissioning any of this activity, and problematising this tension in what's often understood as a win-win scenario. So healthcare costs are reduced and patients are spared possible harms, but actually the work of doing this in practice, of implementing this, of starting to restrict access to interventions, can cause all sorts of problems with contested meanings of overuse among stakeholders and public accusations or fears of rationing. So what I wanted to do just for the last couple of minutes is to return to this issue of thinking sociologically about overdiagnosis and overtreatment. And this is a paper that I had accepted quite recently in Sociology of Health and Illness. And in it, I drew on this really nice work I found by Susie Scott, who's a sociologist at Sussex, who published this paper called A Sociology of Nothing. And I think I liked this for lots of reasons, but predominantly, I think, because of this focus that she suggests on, doing something needs to be accomplished. Doing nothing is still doing something in some ways. And she talks about it really nicely in this quote right at the bottom there. Nothing must be accomplished or done, whether or not we're aware of doing it. So I wanted to think about this in relation to overuse. And what Scott does is to have this distinction between acts of commission, which occur when we deliberately choose to avoid doing something or being something, and that's a conscious, deliberate decision, and acts of omission, which happen much more passively, maybe neglectful or an oversight or failure to act, and that you sort of end up not having done something without really having meant that to be where you get to. And I really like this because I think it's got lots of purchase or analytical purchase for us to start to think about the doing of nothing and how we can distinguish between doing nothing that is intentional and thought through and agreed by everybody against that which is the result of a failure or an oversight or poor care or inaccessible care or whatever it might be. That's just another quote from Scott about this, the value of a symbolic interactionist analysis of how you might accomplish the doing of nothing in practice. So she has a focus on different dimensions of nothing, and I like the focus on inactivity and inertia. So as I've already suggested, I think that the difference between decisions not to, where you've made a deliberate choice to avoid doing something which may have been normatively expected and therefore make you socially conspicuous because you are not doing something, and that might prompt questions about why you are not doing that something, and how that can be an intentional action. Now, this is a graph, I think. I'm not very quantitatively minded. I don't know what any of the numbers and the complicated words mean, but I like this graph or this image because to me, it makes me think, well, if we were going to accept this kind of idea in healthcare that we can choose to do less or to do differently, how at a system level might we think about quality measurement and quality assurance? What might be the tolerances? How would we know if that things weren't happening and that was okay, or things weren't happening because somebody had forgotten to do them or was practicing poorly or had a really inaccessible healthcare service, for example? How would we think about that at a system level? And I think for me, that's one of the really interesting things that I wanted to think about through the fellowship. And I can't claim actually to have any particularly concrete answer about this yet. But one of the things that I'm really interested in is that I think many of the factors that produce overuse aren't going to be resolved by an emphasis on shared decision making alone. That can be part of the solution, but it's not going to be the only solution, because it's insufficient unless we think about the kind of broader social and system related factors as well. And that for both patients and clinicians, the things that people end up doing in healthcare are not necessarily the result of discrete decisions and deliberate intentions, even when they're consciously and carefully made. But often they can be the result of all kinds of norms and expectations and just the things that, you know, the way things happen around here and how we do things that can actually be quite difficult to go against on an individual basis. And doing nothing arguably involves or requires a certain amount of kind of servicing of the medical logic. And that's a lovely form of words that Alan Cribb produced one time when I was having lunch with him and talking about these ideas. You know, that if you're not going to do something, you've got to be able to account for that in some way. And how do you do that within a healthcare system in a way that is acceptable and that sort of ensures that healthcare professionals feel that they're covered or protected against any possible future accusations that they failed to act? And I think it's interesting to think about how we can find ways to tackle these issues that mean that we can do it in a way that fits with patients' own preferences and values and with which healthcare professionals can be comfortable, and that we need to move beyond patients and professionals trying to navigate this quite tricky terrain on their own, often in conflict with the system and other system drivers around them, or at least without any direct support from it. So I'm going to conclude there. These are just some references for the kinds of papers and things that I've talked about. They're all published apart from the one at the bottom, which is a chapter on overuse that we were asked to write for this institute's great big book of improving quality and safety in healthcare. And actually, I think some people on this call are writing other chapters for that book as well. So I will come to a stop there, and I'm really happy to take questions or comments or to have some discussion. And I will stop sharing my screen so that I can see you.
Oh, thank you, Natalie. I've got thoughts running through my head. I wouldn't know where to start in a discussion that was so provocative, really fantastic, and so relevant to many of the pieces of work that are going on in our team. So obviously there's direct relevance to Daisy's work on, which is more about too much healthcare, I guess, or too much bureaucracy in healthcare rather than too much treatment. But some of our other projects, like one led by Luke, for example, is looking directly at uncertainty management in emergency departments. So really to address that kind of issue of how do you manage both patient and staff uncertainty and support them to tolerate uncertainty better, because at the moment uncertainty is leading to over-testing, overdiagnosis, over-admission, and all those other things you referred to. So there's that project that's related to. And then Jane Hayhoe, I don't know if she's on the call, she's doing a really interesting project on safety netting in primary care, which I think speaks directly to your point about doing nothing isn't doing nothing. And actually, if we could reframe that as actually, it might seem like you're doing nothing, but you're not. You're monitoring symptoms, or you're waiting and you're seeing, or you're doing follow-up, or something else. It may not feel quite so threatening and worrying as, well, I've just been left. I'm doing nothing now, or they're doing nothing now. So there's some really interesting thoughts about that. And then Natasha, who's Angela on the screen, and a group of us have been doing some work on transitions of care for older people. And one of the things that's really obvious from that work is that patients have a kind of schema for healthcare, particularly in terms of their hospitals stays, where they expect to do nothing in hospital and they expect to have everything done to them and lots of things done to them. So there's something about, as you say, what patients expect from healthcare as well, and whether we might need to change that. So I'm going to shut up now because, as I say, I've got so many things I'd like to talk about, and maybe we can pick some of them up later. But if other people have questions they would like to ask, could they either raise their hand, come off mute, or pop them in the chat? Oh, I've got one here. So Esme says that she really enjoyed your talk, Natalie, and thank you. And she wondered if you could say something about the connection between overuse, overtreatment, and the socio-legal aspects of care, and specifically the conflicts that come up where when doing nothing is perhaps conflated with giving up. And whether you...
Yeah, no, I think that's a really interesting question. Thank you. Because I think that there is that, as you hinted at, Rebecca, there is that negative connotation of doing nothing as just sort of sitting idly by while dreadful things happen to people, and the idea that you've, somehow considered them not worth investing in or not worth, having activity around. And I think there is sometimes quite that kind of ethical, legal concern about, should I have done something, or should something have happened in this context? And I've got a PhD student at the moment, Fawn Harrod, who some of you might know, who's writing up her thesis at the moment, and she's been looking at care home residents and transfers to hospital, and particularly how staff within care homes make decisions about whether to initiate a transfer to hospital for any particular resident. And one of the things that she's been talking about, or that she's been thinking about in her data, is that even when you've got something like an advanced care plan in place, which says, we wouldn't do these things for this patient in this particular context, that actually when you're in the heat of the moment, it can feel really difficult to not do something that is there as an option. And I think she was, surfacing issues around sometimes residents' families, having that really strong visceral, well, we can't just do nothing, we must do something. And that actually being a really, really difficult position for care home staff to feel themselves in, and then balancing, what might be written down in an advanced care plan, which may be varying degrees of adequacy, against what a resident's family member is kind of saying in your face to you in that moment. And as you say, a lot of this, the care home staff feeling very understandable concerns about, am I going to be covered if I kind of stick to my guns here and say, we're not doing anything, we don't think that a transfer needs to happen, and that feeling like a very vulnerable and exposed place to be as some kind of care or healthcare professional.
Thanks, Natalie. I'm going to hand over to Natasha now to ask her question, because there's a couple of them in the chat. So, Natasha, you might just be better asking it directly. Thank you.
All right, okay. That was brilliant, really interesting. Thank you very much. It was really just about how there's obviously been this huge focus with COVID on testing, and the answer to this is either a vaccine or test more. And Matt Hancock has said recently that he wanted this massive diagnostic capacity to be core to how we treat people in the NHS. So the idea that we test more people all the time, and I think he actually says it. Having built this, we must hold on to it, and afterwards we must use it not just for coronavirus, but for everything, which, you know, testing for everything is, you know, potentially hugely problematic, especially as we think of overdiagnosis and overtreatment. I just wondered on your thoughts.
Yeah, no, I think I think that is really interesting. So I'm one of the things that I do is that I'm a member of the UK National Screening Committee's Adult Reference Group. And you might have seen people like Margaret McCartney and Angela Raffle on Twitter sort of saying, why is this mass screening programme? Why is this not under the oversight of the National Screening Committee in terms of deciding whether this is even a worthwhile thing to be doing or not? And I think that is a very valid point. And I think it comes back again to that issue about, you know, we can do something, so we need to get on and do it. And I think there's such a danger that, you know, the concerns that are being raised about, okay, well, we're doing all of this testing. Do we actually know what the results mean? Where are we in terms of false positives and false negatives? And how do people understand the results that they may be getting? What does that mean? And I think the potential for harms is really easily overlooked or sort of managed away as sort of people griping from the sidelines, rather than having a sort of sensible discussion about, this is a huge investment and there's a huge, you know, opportunity cost in terms of the resource that's being dedicated to this, and what actually is the benefit and what is the potential harm. And I think from the kind of UK National Screening Committee perspective, there does seem to be such, you know, that strong narrative, particularly around things like screening and testing, that, you know, what could possibly be the downside to this. You know, and certainly for screening, you know, there is still that really strong narrative around, you know, sort of motherhood and apple pie, that this is just a fantastic thing to be doing, and it's really proactive. There's something about that kind of proactivity, finding things earlier rather than later, that means it can be really quite difficult to sort of challenge that and say, well, we could do all of this, but actually it's not worth it. And then you obviously get into discussions about what worth it actually means.
Yeah, I think really interesting, it seems to being tested seems to have become a moral thing as well as something that's practical. So sort of this over treatment, over testing, over diagnosis have become embedded in moral choices, but very reductionist.
Yeah, absolutely. And certainly within kind of social science work on population-based screening, there is a lot in the literature about this kind of moral obligation of good citizenship and moral responsibility of engaging with these programs, and what declining to do so actually means in practice. And one of the things that I'm really interested in thinking about quality measurement is that certainly for population-based screening, you know, the kind of quality indicators often revolve around coverage rates and take-up rates and what percentage of people are being screened. And if we are increasingly moving to screening as being an informed decision based on weighing up possible harms and possible benefits, is whether people turn up or not the right quality metric, or should it be something else around being given adequate information and being able to make an informed choice? And if somebody hasn't turned up for screening, even though you've invited them, how many times do you chase them? Is it acceptable to sort of try and nudge them by sending them a timed appointment rather than expecting them to make their own, and all of those sorts of things? You know, do we want to move to people formally declining screening attendance? You know, this act of commission, saying, I've considered it, no thank you, I don't want to attend. Is that where we are? So I think, yeah, those things are really interesting. It's certainly that kind of, you know, the moral display of engaging in health promotion and health prevention. Absolutely.
Thanks.
I think there's some really interesting issues, Natalie, around overuse when you're advocating on behalf of somebody else as well. So when you're talking about diagnosis and treatment for your child, perhaps, or your mother, that differs from when you're talking about your own treatment. So there's some really interesting questions, particularly around commission and omission and the risks and benefits of those. Helen, I'm going to go to you because you had a question in the chat as well.
Oh, thanks. I know we haven't got much time, but when you put that big diagram up, Natalie, with the kind of drivers and potential solutions, it just made me realise, you know, and listening to just how massive this area is, and, you know, trying to actually tackle some of it and do something practical about it is where I'm quite a pragmatic sort of applied researcher, so that's where I'm coming from. So it just made me wonder, you know, have you or has anyone else looked at how these drivers vary by condition, by medical condition or illness? Because I suppose then, you know, putting some kind of boundary around, okay, well, these are the drivers that appear to be working in this particular sort of condition or set of conditions might just help to sort of, yeah, that boundary might help to try and narrow down what the options might be about doing something about it.
Yeah, and I think there is that kind of work, and I've got a PhD student at the moment who's going to be doing some work around maternity care and talking to obstetricians and midwives about defensive practice and really trying to sort of interrogate what is it tangibly that you are afraid of or that you're worried about, and how have those fears kind of manifested and where have they come from, and then kind of doing some work. She's been co-supervised with colleagues in the School of Law, thinking about actually, well, how does this really fit with medical law in this area? So I do think that's important, but then I also think that it won't just be clinical condition. There will be potentially, I think, also issues around you know, broader healthcare settings. There might be particular kinds of patients that healthcare professionals are more comfortable discussing uncertainty with, or having more open discussions with, because they, you know, either know them better, or perhaps on the flip side, they sort of are very concerned that this is a potentially litigious patient who they know has complained about people before. So I think clinical condition is one element of that, but I think there's potentially lots of other stuff going on as well, which means that it's probably more complicated than that. Which is a really unhelpful sociologist thing of kind of saying, well, it's all very complicated and it depends, which I know is not helpful.
Natalie, that was fantastic. It feels like there might be an opportunity for a smaller group of us to get together with a small group of your colleagues and yourself to maybe discuss some of these issues further at some point, because it's such an interesting area. I think both teams are doing quite a lot of work in this, so it would be a great opportunity Peter, I'm sorry, Peter put a question in the chat, but we haven't had time to get to that, so apologies, Peter. Natalie, thank you for trying this WebEx platform out with us today. You're our guinea pig for this, and I think from my point of view, it went really well. So thank you so much for being here and providing us with such fantastic insights today. We'll definitely take them away and learn from them.
Excellent. Well, as I say, it's been a pleasure. Thank you ever so much, and definitely happy to keep the conversation going. That would be great.